Okay. So good morning, everyone. Welcome to the soft launch of the book, Public Health Spatial Planning in Practice. My name is Michael Chang, one of the authors. Just to say, I'll be introducing today, giving a very short introduction before I pass it on to the other two authors and our guest speakers, Professor Rachel Cooper and Professor Matt Ashton. So in terms of today's agenda, we'll go through some key points from the book from the three authors, and then I've asked Rachel Cooper and Matt to provide a response from their perspectives as experts in various policy areas before we finish today with Q&A and discussions with you all. There's a Mentimeter, so if you haven't already done so, it's just good exercise just to put your thoughts onto the Mentimeter, and I'll share the results with you towards the end of today's event. So this is the launch of the book that Carl Petrokofski, Liz Green, and I have worked on the last 3 years. It's been published by Policy Press. It was made available towards the end of September for our UK audience, and I think towards the end of October for North American and other parts of the world. So hopefully you can all access the book. If not, there's that link, as you can see on the screen. They've been given a 50% discount by Policy Press. So if you haven't already bought the book or accessed it, you can use that code until the end of November. So in terms of today's agenda, I would just like to say, firstly, thank you to everyone for taking the time to join us today. It's an exciting book, and hopefully many of you will recognize the things that we have put in the book based on our practical experience from the three different authors. So in terms of the book, just to kick off my introduction, so in terms of the background to the book, so we began the process back in late 2018, early 2019, so before the pandemic, before all these issues came around, and we thought, okay, we've all worked in different areas of spatial planning and public health, from Liz Green and Carl Petrokofski across England, across the UK, Wales, and we thought we had to put something in one cohesive place because many publications have been done in very different formats and different organizations, and I think having one resource will be really useful, and that's pretty much the starting point for the book. We wanted to make sure it's practical. We've realized that there are many publications out there looking at planning for health, environment, and then other aspects of the agenda, but making it very practical, useful for practitioners and students is something that we strive for. So hopefully that came through very clearly in the book. In terms of the contents of the book and the structure, so it's broken up into three different bits. One is the background context. We kind of have to set the scene in terms of what the evidence is telling us at this point in time around the relationship between the built environment and public health issues and health inequalities. That's the kind of first bit of it. The second bit was around health and other forms of levers and powers that we can use, primarily the impact assessment world. So Liz Green wrote that we're looking at health impact assessments, health and law policies, and other impact assessments that we all come across in our day-to-day work. And then the third bit, looking at planning policy, planning decisions, and how do we embed health into those different processes and systems, and then drawing all together in a horizon scanning, looking at what's coming up. And just when we were finishing the book, the pandemic kind of obviously came, and we had to mention it, I think, in a book. So you'll see it in the horizon scanning section of the book. So hopefully that's a quite clear structure. In terms of making it practical, we've had various different things and contributions from experts from around the world, from Australia, from America, from across the UK as well, looking at how they're doing planning for health, both in terms of policy and decision making, but also in terms of the workforce and the people capacity building issues that they are addressing there as well. So thank you for those insider story contributors, many of you who are joining today. So thank you very much for making the book come alive. So just to kind of finish off my introduction before passing over to Carl and then Liz. In terms of the book, there are three propositions, if you like, which we put forward. that underpin the book. One is the built and natural environment matters to health. And Carl will go through the evidence and what we already know around the evidence base around the relation between the built environment and health. And I know Rachel Cooper will mention the work that she has done with the Commission for Creating Healthy Cities, updating the evidence actually around some of these areas. The second proposition is looking at the planning system, why it matters to health. The planning system is a critical tool used by both policymakers and local communities, public health professionals, in order to deliver multiple objectives, including public health. And therefore, it's a very important system tool, but also a process for delivering and thinking about health issues. The final proposition is looking at the workforce and why it matters to health. And this is looking at those working in spatial planning, or those working in public health, but also other allied professionals, transport, housing, regeneration, environmental health, engineers, all those people working within the planning system and in places, because in a way, they use the planning system to meet their objectives, and why they're so important in driving some of those agenda forward, because ultimately policies and decisions made by people, and people matters. So that's why it's very important. And we highlight various different forms of building capacity within the workforce, either within existing educational requirements or professional development activities, or in some councils across the world, actually, the UK, Australia, America, where they have dedicated built environment and health professionals working in the space as their day job, rather than as part of the portfolio, and they can dedicate their time and expertise into this. So those are the three key propositions underpinning the book, which I hope you would agree with that. And any comments, please do post in the chats as well. So finally, to kind of say, when I draw everything to a close after Cara and Liz's presentation, I'll try and mention how this agenda is very relevant to what we're facing currently, not just with COVID, but the cost of living crisis, and how planning for health is an important mechanism for addressing those public health challenges we face now and in the future. So with that, I'll introduce our speakers. So firstly, Carl Petrokofski, one of the co-authors, he's a consultant in public health, and he will provide an overview of the evidence shortly around the built environment and health. And then we have Liz Green, another consultant in public health, working in Wales, looking at the impact assessment world and what that means for our agenda. And then we have Professor Richard Cooper, who was Professor of Design Management and Policy at Lancaster University, a very distinguished expert with multiple publications in design policy and health and well-being, recently a member of the Commission for Creating Healthy Cities, which she will introduce as well. And then finally, Professor Matt Ashton, Director of Public Health for Liverpool City Council and Chair of the Association of Directors of Public Health Policy Advisory Group on Healthy Places. So a very distinguished panel of authors and experts, and hopefully you will enjoy today. And any questions you have, please post in the chat or in the Q&A. So over to you, Carl. Thank you.
Okay, thank you, Michael. I'm just trying to share my screen. Hopefully people can see that now.
Yes, go ahead.
Yeah. Oh. Right. Good morning, everyone. Firstly, thank you so much for joining us. We're really grateful, and we hope you find today a really worthwhile use of your time. My name's Carl Petrokofski, as Michael said. I'm a consultant in public health. I work currently for the UK Health Security Agency, but previously I was working for Public Health England and leading the Healthy Places team. I'm also a visiting professor at the University of the West of England. Now, in the book, I'm assuming most people have not seen it. The first thing we say is to put the book down once you've bought it, and to go take a walk outside and really to look at how your local environment is, what it's shaped like. How are people using the spaces individually and in groups? And how is the design of those buildings, roads, parks influencing their behaviors and yours, and possibly your health? I'm not going to ask you all to put down and go take a walk outside right now, but save that for another time. Michael's outlined the three overall propositions that we've built the book around. That, our first proposition, that the built and natural environment does matter to health, and that planning is the way to try to be the intermediary, and planning matters to health as well. And also, and I'm going to talk a little bit about this, around how the professional workforce, that's particularly public health professionals and the built environment professionals, really have an impact on health and well-being. Now, you'll be pleased to know that this slide and these pictures are not in the book, but your health is determined by three major factors. Firstly, who you are. What's your age, what's your genetic background, and those are things we all carry with us individually. Your behavior is also influenced, your health is influenced by your behavior, what you do, what is your background in terms of education, jobs, what are your social networks? And we all know there's good evidence that that influences your health and well-being. And lastly, your health and well-being is influenced to a large extent around your local environment and the infrastructure, the built environment. And that is the focus, this last one, of the book today. But more prosaically, and this is in the book, another way of showing this is how your health is determined by who you are, what you do, where you live, and that's the realm of where we are today with today's book. But also, and I think it's important to say, where you don't live. A volcano erupts in Iceland, and we see impacts on living here in the UK, and that's also obviously climate change is the biggie here. Now, I'm not going to go through this slide in details, and all of these are in the book, and we'll also make the slides available. But I think the key thing here is there is a developing evidence base showing how the built and natural environment impacts on health and well-being. And the impacts are both direct and indirect. And so, for example, we know that noise, excessive noise, impacts on a whole range of health conditions, from asthma, depression, even cardiovascular disease, to other more subtle impacts of how the built environment will impact on, for example, whether your kids will take a bike to school because you as a parent may decide it's far too dangerous for them to be out cycling on dangerous roads. That has an impact on our physical activity, which in turn, as we are increasingly seeing, has huge impacts on health and well-being. Now, again, colleagues have shown how the built environment impacts directly and indirectly on health and well-being. And again, I don't want to go through these in great detail, but to use the example here of transport policies and how the urban design on the left-hand side will influence our behaviors, whether the transport infrastructure is there that will allow you to use modes of active transport, public transport, or actually to use cycling and walking and other opportunities for wheeling. It will impact on, therefore, the amount of air pollution, noise that is in the environment, which in turn will impact either directly or indirectly on cardiovascular, respiratory disease, and a whole range of other diseases, as we're seeing. And underpinned by the context of, what is the local socioeconomic environment, what's your own personal genetic environment, etc. Now, the physical environment can be either hazardous or protective, and it depends on a whole range of issues, for example, housing, neighborhood design, and your natural environment. And how does this express itself? Well, we see that for life expectancy, we see, for example, in the UK, over 9-year differences in life expectancy for men between those living in the most and the least deprived areas. And we know within local areas, these differences are even greater. And we see similar differences of about 8 years for women. There's another measure that we use in public health called healthy life expectancy. And this recent report has shown that there's really a 19-year difference between the most and the least deprived local authorities of how long you can expect to live a healthy life between those in those different areas. Now, the built environment is not the single most determining factor. As I've shown, your behavior and your own personal genetic background and age will influence that. But we know the built environment has a huge impact on that as well. Now, what are some of the impacts that we see? Well, there is a cost to this. There's a cost of poor design, both at an individual basis and on the public purse. For example, we know that poor housing costs the NHS about £1.4 billion per year, and wider impacts such as poorer educational results and decreased job prospects are estimated at nearly £18.5 billion per year. Similarly, we know that air quality contributes to at least 25,000 deaths and costs the UK economy about £16 billion per annum. And the main source of this being road transport, especially industry, agriculture, and emissions from the home. We know that green spaces are good for your health, and access to those is highly variable around the country. We know that about 2.1 billion could be saved if everyone in England had good access to green space, largely due to the increased physical activity in those spaces. And we know that inactivity contributes to about 1 in 6 deaths in the UK. Reductions in health inequalities. As I've shown, demonstrated before, there's a huge variation in life expectancy. We know that reducing health inequality has a potential to save something like £31 billion per annum in productivity losses and £20 billion per annum in lost taxes. And we also know that there's a cost if we could improve better community cohesion. And for example, the built environment, road traffic, and poor urban design are significant contributors to what we call community severance. And we know that better design could again improve health and well-being in this sphere. But the challenge is how do we move from areas where it's unsafe to have our children walking on roads to get to school, or bleak urban landscapes with poor housing, to areas that most people would automatically see as just looking, and the evidence does support this, supporting health and well-being. Well, we know that in any planning project, we need to strike a balance between the benefits, costs, and the trade-offs that different stakeholders who will be in the planning process may have different aims, objectives, and agendas. We have to somehow balance those. But we also know that there are many opportunities for better health and well-being if health considerations can be factored in at the start of a development project. Now, if they aren't, there's the danger of significant health impacts and healthcare costs being stored up for the future. And how do we move to that is one of the key things is to develop good links and communication between built environment and public health professionals and others involved in the planning process. And I can tell you as a public health consultant, this was not in my training originally. We all knew about bad environments and housing to some extent, but it's the wider issues of urban design and transport, which is newly arrived onto most public health practitioners' agendas. And now we really need to make that a reality. And by engaging with local communities and showing that local health needs are incorporated into the design and planning of infrastructure projects, we really hope that to see improvements in the future. Public health professionals can bring a whole range of skills and attributes to the planning system table. Firstly, Public health professionals can help others understand the impacts of, for example, transport and leisure policies and the importance they play on health and well-being. Public health colleagues can identify, find, and interpret the evidence base, but also the art of public health is how to interpret this evidence base and provide ideas on courses of action to take, in an area when the evidence is often messy and it's not as clear cut as we would wish it to be. We can help identify what the health needs of the locality are, and also the development of research and evaluative frameworks to looking at the impacts of local planning developments. Support with aligning stakeholders, I say, is a key skill that public health professionals can bring. But there is a challenge. And the challenge is for public health professionals to develop those skills and the understanding of the planning system and of planners and of those in the built environment, particularly those in the commercial sphere. Again, that's not something that coming through the training for public health is necessarily on the agenda. And we need to see how we can improve that. So in summary, it's long been recognized that living in poor environments can have significant health consequences. The built environment impacts on health and well-being both directly and indirectly. Planning and the design of the public realm supports or hinders the ability of people to adapt healthier lifestyles or significantly influences their exposure to environmental hazards. The distribution of risks to health across localities arising from poor environmental conditions is not equal and plays an important part in the inequalities in health outcomes which are observed between more deprived and less deprived communities. Though the evidence base supporting these assertions is developing, and by and large, we know what to do. The challenge now is to ensure that health improvement becomes a fundamental design principle underpinning all planning decisions, and that public health and built environment professionals have the knowledge, skills, and experience to contribute effectively. And unless we do this, we stand no chance of addressing the wider health issues and inequalities affecting local communities and the nation. Okay, thanks very much. Okay, back to you, Michael.
Thank you, Carl, for that. It's a very good introduction to the evidence and what we hopefully should all understand already. And I know there's a lot of interest in the evidence and the background documents. So we'll share the slide, and obviously there's a chapter on values and outcomes in the book as well. So thank you for that. And next we have Liz Green, looking at the impact assessment world. Over to you, Liz. Thank you.
Thanks so much. Right. Can you tell me if you can see that?
Yes, that's on full screen. Thank you.
Fabulous. Thank you. Right. Okay. So thanks, Carl. And I'm just going to sort of talk you through the section that I wrote, and also some of the tools and processes that we all have available to us to build health and all policies and effective. I've put effective impact assessments in spatial planning, but really we're talking about effective and good spatial planning that's good for people. That's at the heart of it, inequalities. Before I move on, I'd just like to say thank you to Lee Parry-Williams, who has been my partner in crime on a lot of this journey, although she's not a contributor to the book, but yeah, she's been excellent on this learning curve from the start around spatial planning and health, because I, like Carl, I'm a consultant in public health. I'm Programme Director for Health Impact Assessment and a visiting professor at University of West of England, and the day job's very much in Public Health Wales, our National Public Health Institute. So talking of National Public Health Institutes and our focus, for the last couple of years, it's been on COVID, and COVID very much exposed a range of health inequalities that Carl was talking about. And some of this is actually to do with where we live as much as how we live. And areas of deprivation, more overcrowded housing, we're all seen as significant, contributors to what happened through the pandemic. through the lockdowns that we had, through the requirement for us all to work at home, which, as you can see, many of us still are. And actually, in terms of our whether you were furloughed or not, how that affected your income, whether you could remain in your home or in good quality housing, either during the pandemic or when the protections were ended afterwards. And so actually, I know it was an awful time, it's still ongoing, but it has presented a window of opportunity for health practitioners and land use, spatial planning officers to reflect on some of this, I feel. And we know we've all had this lived experience and we see a lot of differences. So you could have had a better experience of the pandemic and working from home and being locked in if you lived in a 4-bedroomed house, you had a big garden, you had space for an office to do your work and still have your Zoom or Teams calls or whatever. But if you lived in a small flat, no access to green space nearby, then, you know, and you have a small family, things were very challenging. So we know that actually where we live, our environment, our home environment, our outside environment, all had a massive impact on our experiences. And I think this has really definitely shown up how we need to move forward and really think about how we almost pandemic proof our housing and our land use planning going forward. And so what am I talking about with health and all policies? For many of you who are public health, you probably know this, but we're talking about a systematic approach where we seek synergies, integration with other traditionally described non-health sectors, such as land use planning, transport planning, waste planning, or housing. But as Carl rightly pointed out, those are all determinants of health. And so we should be working together, and we can see where that overlaps and account for any decisions or policies and try to look at them and say, okay, so how can we avoid any harmful health impacts? And with the best will in the world, sometimes we write our policies just from our own perspectives. So it's not about negative health impacts. It's often about unintentional negative health impacts. And those unintentional ones can also have positive impacts. And it's about looking at the population, looking at how people's real lives, what affects us, what affects you, what affects the people that we serve if we work in public service. So one of the best tools to address this is impact assessment. And coming from a health impact assessment perspective, you would obviously expect me to say, well, HIA is the best tool for this. But it is the main driver to implement health and all policies because it considers explicitly health in the holistic sense, well-being, because that includes not just your physical health, but your mental well-being, your social well-being, and equity. So the distribution of the effects of a policy, a plan, or a project. And HIA can be either standalone or it can be integrated into other impact assessments, such as strategic environmental assessment, which is applied for policies, or environmental impact assessment, which is applied at a project and a development level. But when we talk about health and impact assessment, well, actually, there are several other tools. So we've got environmental impact assessment, which looks at human and population health. Strategic environmental assessment, again, same. Sustainability appraisal, which is sort of interchangeable with SEA. And then you've got HIA, which looks at it in a much broader sense. That's health, well-being, and inequalities. That's not to say EIA and SEA don't look at the impacts on people, but actually, you know, it's termed receptors, which is almost a bit sort of dehumanizing, but that's just my personal perspective. So, and so a lot of you who are planners or who work on this agenda would say, well, actually, we do that. We do consider health. There it is. There's the drivers. We do it. But actually, what matters are those definitions of health and the perspectives that we take. So there are several models of health. So you've got physical model, which is mainly around, you know, how ill you are, sickness, if you're poorly, doctors, nurses, healthcare services tends to be within that model. The environmental model, which is where it's looking at much broader, so physical, and then the environmental aspects, those determinants like air quality, noise, emissions, housing. And then you've got a move through to a holistic model, health, well-being, inequalities, looks at it physical, social, mental well-being, the WHO definition. And then you've got this wellness model. So what creates health and well-being? What keeps us well? So you've got those different different perspectives. And a lot of impact assessments look purely at environmental model. And what we want to do is move it so that we look at that more holistic model and aspire to that wellness model. What keeps us well? Well-designed spaces, places, and housing will keep us well and will keep us out, hopefully, of using healthcare services. So there's quite a lot of benefits to promoting and building in holistic health and using tools like HIA, for example. So you look at that distribution. You also identify positives. You can capture what you're doing well. Is there any added value, any opportunities for us to make things better? If you have a well-designed space and a plan for it, what can we do to maximize it? You can look at the unintended negative impacts and look at potential mitigation. What can we do to reduce it? And you can show that actually, you know, I've put the words due diligence there, but really demonstrate and practice that you've thought these things through. It's evidence-based. It strengthens partnership working. HIA is a very good vehicle to bring people together to see each other's perspectives and talk about different issues and how you can overcome them. It enhances people's understanding about how we all should work together. You know, it's not just about health sort of being built into spatial planning and saying, you naughty planners. It's actually about, well, actually, we can learn as public health professionals so that we can think these things through and help each other to address them. And HIA and lots of these tools are participatory. People's real lived experience of things like living in a pandemic and a lockdown matters. And actually, that's really important because that's really fantastic evidence and contextual knowledge. I'm about to finish. I'm about to say, I'm just going to show you how an impact assessment that myself and Lee carried out in West Rill in North Wales made a difference. It was a HIA, area of deprivation, regeneration area. We carried out a HIA with lots of community and stakeholder engagement, and we helped to change the streets from this to that. Thank you very much.
Thank you, Liz. Very useful pointers there, and I know there's the various publications from Public Health Wales as well from on HIS and other forms of impact assessment. So thank you very much. There are a few questions in the chat which we'll pick up after 11 o'clock. Given the time, I think I will wrap up. I think our key messages after 11 o'clock. So I think I'll move on to Rachel Cooper and then Matt Ashton as well. So I've asked Rachel Cooper to provide a response, given her expertise in the area. So Rachel, over to you. Thank you. You don't need Rachel.
Yep, you can hear me.
Thank you.
Everybody, I do that all the time. I'm Rachel Mute, I think, rather than Rachel Cooper. Thank you very much. Thank you very much for asking me to give you a response. It was great. I have actually had a chance to not read it in detail, but to look at the book and then go for a walk. I've been working in this area for a really long time, but I'm a designer. So I look at it from a designer's perspective, and I'm going to bring some of that to you. And there's 4 things I want to just talk about briefly. One is a response to what I've heard, and another one is a little bit of an overview of the Commission for Creating Healthy Cities, which I was on and we just published recently. But let me give me a response to the book. And actually, my response has some questions or challenges for our participants. And I want to talk about three things: the cost and the price, economics, philosophy, and action. And a lot of what's in the book is great, and we've heard a lot of it before, but it's a really useful book because it brings it together for both the planners and the professional health experts. So it's great sort of synthesis of what both need to know. One of the things that in the book and in the Commission for Creating Healthy Cities was all about the cost. And when Carl listed the cost of everything, I tallied it up to 90 billion. And I've got a similar document that says 1.4 billion could be saved to the NHS if we invested more in poor homes. And the same figures keep coming through. Now, if you're somebody working in the Treasury, let's say, you can have all these figures in front of you, but what you also need is the price. So if you go to a local authority and say, we've got to renovate this street and we've got to renovate these homes, currently and going forward, they're going to see, and how much is that going to cost? So you're always going to have this debate. Yes, we have the evidence, but what's it going to cost? And this brings me to the sort of what's going to happen in our new budget when they start cutting everything. We can go back and say, yes, but you could save 1.4 million. They're going to say, yes, but how much do we have to put in to save? So there's always this debate, and this is what we're always struggling with. So we need more details on the price versus the cost. And so let's think, we've got to think about the economics. The other one is philosophy. When I've worked as a designer and I've consulted with clients and other architects doing master plans, and the client will have all the ambitions of having a healthy place, a sustainable place, and the designer comes along and they come along with ideas and all these wonderful green spaces and no cars. And then the client goes, okay, what is the value of that? How will I sell this on? What will a developer, want to pay for it? What is the long-term value? And then you have what I call a sort of a scales, value versus values. And how can you change the values of people who see pound signs, dollar signs, rather than going forward and making investments based on what I would call socially responsible design values. So the other thing we've got to look at is people's values, their philosophies, and changing their decision-making, their design decision-making, their decision-making. And in terms of philosophy, I come back to just what Liz has just been talking about, health in all policies. When I've worked on sustainable cities, you start looking at, we've got to be sustainability in all policies. It's got to be the environment in all policies. And so you get this, well, what are we, we've got to get everything in all policies. And I think what we've got to start thinking about is the wellness of everything. The wellness of people and planet, but the wellness of our digital systems. So when you're designing places and they're going to have more technology in them, we're looking at systems thinking and how we ensure we have wellness, not just in people, but in planet, in the services and the digital systems and the physical systems. So it's, again, broadening the philosophy and looking at how we can help local authorities put systems thinking in place. And I'd take that further. We do work now on beyond human-centered design. So when you're designing something, you're not just designing for the human, you're designing to make sure the soil is healthy, that the building is healthy, that the physical artifacts are healthy. So it's beyond human-centered design. We're not just looking at the human, we're looking at everything that surrounds it. So another thought. And finally, action. So the book focuses on professionals and policymakers. And as I've just said, we have the economics here, we've got to put that into it. So how can we start to think about, and the book does talk about this, the communities. So the other area is designing for the commons. Now, we used to have the commons, the middle of a village that all the community owned. And they took ownership in that commons. So now we're talking more about what sort of process can you enable people to feel ownership and support them in a sort of communized, not commons in the sort of Russia side of it, but communized design that enables the commons to be involved in that, because we know going forward for the next few years at least we won't have the economics coming from the Treasury to invest. So how can we change our thinking there? So those are my responses to the book. I don't think I've got much time left. I just wanted to talk a little briefly because it mirrors this. So about 2 years ago, just at the start of the pandemic, Lord Richard Best, who used to be head of Rowntree, commissioned a group of people to develop a commission for creating healthy cities. It was backed by the Prince's Trust and Prince Charles, and we formed a commissioning groups. We had 3 groups. Subgroup A, which was built environment, and I chaired that one. Subgroup B, which was on transport and mobility and technology in cities, and that was led by David Bannister, professor at UCL. And then there was subgroup C, which was health and well-being, which was Dr. Michael Dixon, who actually is now the King's physician, so he led that one. And then there was a research team at Oxford that did all the data collection, and they and then we had a call for evidence. We had all sorts of data collection, 250 systematic reviews, evidence from local authorities, and we worked with the mayors of 2 cities in the UK, Bristol and Nottingham, and that we resulted in the Commission's overarching recommendation was health creation interventions that positively improve health and well-being should be the determining factor for built environment planning and place-based policies, reflecting exactly what the book is talking about. And it made 21 recommendations. There was a series of recommendations on the built environment about more affordable housing, health-related planning. One of them, which I think is very important, was local control. What we see is a disconnect between central government and local government, and often policymaking in central government really sometimes clashes with local government. And I did a study like Liz of COVID and how local authorities could respond to COVID. And in Lancaster, where I did a case study, it was clear that central policymaking was hindering local policymaking in the response to COVID. So we really do need to give more control back to local government. The other area we talked about was design quality and building that into plans, which I think is again into we had 3 recommendations on transport and mobility, reducing car dependency, looking at better transport planning and wider support. We had a series of 3 more on planning for exercise and support for community-run initiatives. So this is exactly the same as and access to better food, and also social prescribing. But the 4 final ones were on good governance recommendations, and we're repeating it, interdepartmental coordination. Much more, and this idea of the professional, the public health professional in planning or vice versa is very important. Devolution to local government, more civic engagement and prioritizing health outcomes, and then we built a database of all the evidence, and it's accessible now, so you can actually go in and look at all the papers and and the robust evidence. And we also did some using analytics with the 2 cities to actually map different levels of social deprivation, work in employment, health indicators, planning indicators. So again, all that analytical work still needs to go on. And I have to say, when we did that analytical work, it's quite costly and it's time consuming, and places like Manchester can do it, places like London can do it, but if you're a small town, you haven't got the skills and analytics to do it. So there's a lot for us to do. And I'd say we've still got to do more work on the economics, cost versus price. We've still got to push people's philosophy, drive that sort of wellness of everything, systems thinking approach. But we've got to enable action. And I think that's how we think about action going forward in the next few years, when we've got quite a crisis, not just in the UK, but I'd say in the developed world, and we've got a whole developing world that needs a lot of this help in this area. So thank you very much for this book, and I hope that stimulates some questions and some discussion.
Thank you, Rachel. Definitely on cost and price, they're very, very kind of relevant, and obviously on philosophy and on action taking as well. We'll pick up those points later on. Just to say, I have posted the commission's link in the chat, so please have a look at it, and we'll circulate the link afterwards as well. Thank you, Rachel. So just to finish off the contributions from the speakers and the authors, I'd like to bring in Matt Ashton from Liverpool City Council for your thoughts. Over to you, Matt. Thank you.
Thanks, Michael, and thanks to everybody who's spoken so far. Some really good insight from Rachel there. I've got a couple of thoughts, if I may. I think the first thing to do really is to congratulate Liz, Carl, and Michael on an excellent resource, and that really does bring information and disciplines together. So thank you very much for the work you've been doing and the leadership you've shown in this area. A quick reminder about why health matters, and I think this has been stated. So health is very important. It's very important from an equity or a justice or fairness perspective, absolutely. But that isn't the only reason why it's important. It's important because poor health costs a lot of money, and lost productivity costs a lot of money. So the cost element of this is really helpful for people who perhaps don't always understand the public health argument about why health matters. We do absolutely need to focus on the economic element of why poor health and why good health matters. And just to make that point, I use that narrative depending on the audience that I'm speaking to make the case for why things are important and why things need to happen or need to change. Michael Marmot, back in 2017 said, what good does it do to treat people and send them back to the conditions that made them sick in the first place? And that's absolutely right. If you think about what influences health outcomes, healthcare is an important element of it, but it's not the only element of it. The built environment is an important element. Lifestyles and decisions that people make about their individual choices also heavily depend on the built environment, on the physical environment, on their work and their employment, on their education, and so on. So we really have to take a holistic approach to improving health and well-being if we want to make a difference. I think the third thing I'd say is, the links between planning and health are nothing new. We can go back to Greek and Roman times for how they did good design and how they tried to build in good health into some of their towns. In this country, in England, back in the 1840s and 1850s, we had public health pioneers like John Snow with the link between cholera and poor health. And we also had, in my neck of the woods, famously Dr. Duncan, the first medical officer for health back in 1847, who worked with the borough engineer and with the then statutory officer for nuisance, so in effect the environmental health officer, to really understand the harm that some of our housing was doing to people's lives and putting steps in place to rectify that. So this is nothing new. And of course, I think planners know this, and I think public health folk know this. So I don't think this is about highlighting an issue that people aren't aware of. It's just how can we make this happen better, more sustainably in the future. I would also say that the pandemic has given us an opportunity. Now, the pandemic has been horrific, hasn't it? The last 2 to 3 years has been awful for everybody. But one of the consequences of the pandemic is we do talk about vulnerability, we talk about inequalities, we talk about public health, and we talk about health outcomes a lot more than we've done before. And I think that is a really good opportunity for us to pin this work on. How do we improve health outcomes? How do we protect our populations? How do we actually address inequalities in the future? In the hypothesis in the book talks about the built environment matters to health. Of course it does, absolutely. It talks about planning matters to health, absolutely. And it talks about the professional workforce matters to health, which of course it does. I'd just like to pick up on that last point a little bit. So the professional workforce is broad, and we need to encourage people to work together to bring their disciplines together to have maximum impact on this agenda. So that's public health folk, it's planners, but it's broader than that. And I do think the thing that's missing from this for me is the voice of the community. And I think, Rachel, this might speak to your point about political will. If the political will isn't there, community will can be there and is there. And if we maximize our community will, if we take a bottom-up approach rather than a top-down approach to this, we can really highlight some of the disparities, the inequities in our communities, and why action is required. And I'm just going to finish on a thought about community, if I may. So the book says this stuff doesn't happen by magic, and I couldn't agree more. But what I would say is, if this stuff happens, the results can be magical. And I think one of the ingredients can be our community. The voice of our community is incredibly important in the planning process, incredibly important in public health discussions. But inequalities are a real issue in our communities, and we know that there are some communities that we work with who are very able to speak up on their own behalf and very able to make the case for why health needs to be better and why the planned environment, the built environment needs to be better. But there are other communities that need greater support to help them make the case. So I think for me, there is also something about how do we maximize the voice of our communities in this discussion, particularly in our most vulnerable communities. I just want to conclude by saying, look, congratulations. Thank you very much for the work you're doing on this, and I look forward to working with you both in Liverpool in my place, but also through the Association of Directors of Public Health and the Policy Advisory Group that I chair, because there's absolutely a willingness and a determination in the public health profession to improve people's lives through doing good planning. Thank you.
Thank you very much, Matt. Yeah, very powerful kind of concluding comments there. So thank you very much. I do agree with all the things that you and Rachel have said, and your expertise and insight, are really, really useful. I should add that obviously the book is only part of a bigger picture of things that we're all doing individually. So it's not meant to be the only thing. And there are obviously gaps in the book, and just because of the fact that we work in a professional setting, the community elements should come strongly a bit more in everything that we do. At the same time, with the planning system, the system is there for everyone to access. And I do agree that actually people do need to be able to access the planning system and the public health system in a really straightforward way. In some ways, we can be bogged down with jargon, and in some ways, planning lawyers are there to keep us in check in terms of what we can and can't do legally. And those are the conversations we're having now nationally with the Levelling Up Bill in England and everything else as well. So I do agree with that. And there are other organizations like Locality, working with communities, and Quality of Life Foundation working in communities and making sure they can use the planning system and other kind of systems in a really effective way. So yeah, I do agree with many of the points that you've all made. So thank you very much for that. There are a few kind of comments and questions in the chat, and I'll pick them up after 11 o'clock. Just before we prepare for a 2-minute silence at 11 o'clock, I just want to say, firstly, there are a few, just to say, we are trying to engage with the developers as well. We do have a few developers in the private sector contributing to the book. So Andrew Taylor from Countryside and Harry Nebb and Olga Turner looking at value as well. And the points about value and values, it's really coming forward through in their contributions. But there's obviously a lot more work to be done involving the private sector and those who have the means to invest in some of these issues. And then finally, one point, I think it was Maggie kind of mentioned the point about the environment in itself is not enough, and I do agree with that. And I think, Carl, did you show your diagram from Barton and Grant? And obviously, as a planner, I work within the environmental, physical, social space, and there are other things which Rachel mentioned around prescribing, which can be looking at bringing communities together to use the space a bit more properly and for their own use. So it's part of a bigger picture that we all need to be aware of where we stand and what our role is. So definitely, we do work with the system, not just individually. That's why the book is aimed at anyone working within place and the planning system to deliver healthy placemaking. It's not just aimed at professional disciplines, it's aimed at anyone who is interested. It is 10:49, Katie. So 11 o'clock, we will pause for 2 minutes, and we'll come back in 2 minutes for Q&A and discussions and picking up on those points that you all raised in the chat. So thank you very much. So let's wait for 2 minutes for the 2-minute silence, and then thank you. Okay. Thank you, everyone, for the 2-minute silence. So just to kind of draw today's event to a close before the Q&As, as I was mentioned earlier, the book was conceived quite early in 2019 before the pandemic. And obviously now in 2022, things have moved on a lot. There are a few issues actually that they are more relevant now than when we first started doing the book. And there's a section on horizon scanning, how you look forward. And many organizations are looking at scenario planning as well when they look forward. After all, spatial planning looks forward 10, 15, 20 years. It's not just the next 1 to 5 years. So others mentioned around health inequalities and all those issues, which are now even more relevant than before. So of course, we have to think about those challenges as well. But I think just being more positive as well, there are exciting trends and now and for the future, and opportunities for innovation and creation in the built environment through digital and other kind of tools and mechanisms that we have now to really drive inclusive, sustainable economy. So I think with that, I would really like to just finish with 3 overarching thoughts to finish all the kind of formal presentations. So firstly, as Rachel mentioned, and as Carl has highlighted, there are many, the evidence base is very clear. And actually since Sir Terry Farrell's reports about 10 or so years ago with DCMS, or the evidence in terms of the messaging around the built environment and health haven't really changed a lot. We know what we have to do. I think it's about how we do it, and it's one of the key messages from today is how do we take action, and hope the book helps you do that locally and in your different work environments. And there are many others who are working in this space, helping us promote the messages, taking action, building capacity. So definitely international level. The WHO, the UN Habitat have done a lot of work in this area, and are doing a lot of work in this area in the next few years, looking at capacity building. And those from non-governmental organizations, the NGOs, the third sector, the town and country planning associations, the quality of life foundations, and all those kind of what works well-being centers, keep building the evidence and providing evidence in a way that practitioners and policymakers can actually use in day-to-day decisions. So that's very, very important and useful for us all. But again, it's about putting people in places at the heart of placemaking. And the planning system is very central to this, as I would say, as a town planner. And I would just refer back to the Welsh Government's documents on the planning system delivering resilient and brighter futures, which was published during the early peaks of the COVID-19 in July 2020, really highlighting the role of planning, the spatial planning system, placemaking, in tackling some of these challenges we face in public health and health inequalities. And for England in particular, the 11 departments have published some key research avenues or areas of interest for researchers, looking at what planning interventions can work and show to work that can support prosperity, health and well-being. So we're beginning to really work with researchers and academics to build the evidence, or action-oriented evidence as well. And then finally, I think Matt working in local government, others working in local governments, I completely understand resource constraints. And I think the reason why we want to highlight workforce in the book is we know that at the end of the day, people and the professionals in the communities are the ones who will make things work or don't work, even those in developing nations and in other sectors as well. And I know the challenges faced by local governments, central government, in the public sector, in every sector. And so the case for investment, as Rachel mentioned, looking at the value and the values, the costs, is really quite important. So we have to move beyond just saying the cost of inaction is billions of pounds to the NHS, but how do we invest in infrastructure? How much will that cost? And how can we bring forward affordable places for people to live, work and play? So there's a strong case for investing in people in the workforce. And it doesn't necessarily mean additional manpower or people power or staffing costs. It may just be looking at how do you train people in a more effective way? How do you bring more skills and knowledge into the curriculum for registrars or those in postgraduate education to really dive into this agenda? So finally, I really encourage you to get hold of the book if you can, with that discount ending towards the end of November. There is a policy briefing done by Policy Press to help those pick out key messages from the book. So that's the link we'll circulate afterwards. There's a lot of interest and a lot of people really promoting the agenda, doing lots of events and conferences. And so if there's interest in doing more events and more action-oriented workshops around this topic area and different subtopics within planning for health, then please get in touch. I know colleagues at Savills are really looking into this as well. So finally, as I mentioned earlier before the 11 o'clock, the book is part of a wider, bigger set of activities or program of work from governmental organizations and NGOs. So let's keep the conversations going, and most importantly, let's take meaningful action so we can make a difference to communities and places on the ground. So thank you very much for your time and participation in today's presentations. So going to the questions then for our panel. Thank you, Lee, for that. So I'll kind of ask different panel members to address the questions. I think the first thing really just from Angie Jukes is, were inequalities impact assessment reflected in the research? I think that's referring to you, Liz. Don't know whether you picked up that response in the chat. If you can just address that as well.
Yes, I did, because there is a move to integration for equalities impact assessment, but I don't actually ever really come across many that are part of spatial planning developments. And so if I'd carried on writing about all the different impact assessments in the book, then it would have been as long as the book itself. But yes, we did consider it, and yes, there's another move for integration there, but sometimes equalities impact assessment tends to just focus in on the protected characteristics in terms of population groups, rather than that broad holistic approach that I described.
Thank you.
And that's just our personal experience, my personal experience.
Thank you, that's fine. Okay, so let's go on to the value and values issue a bit more. Natasha Reid kind of suggested, the value piece seems critical to take health and well-being and social sustainability from nice to have to need to have for developers. And I wonder whether Rachel can say something more about that as well. And then I'll come to Matt afterwards. You're on mute, Rachel.
Rachel mute. Yeah, I mean, I could go on this on about this for a long time. I think somebody else wrote in the comments about this won't change until people have combined budgets between, because there's a, you know, local authorities think, well, why do this if NHS is benefiting? Then there was a discussion further on, I can't find it now, about, well, that's a red herring because local authorities have a, you know, social care, but maybe they disconnect that whole, you know, out of the NHS into community, the costs, and they're actually juggling. They're throwing it, the baton backwards and forwards. And in fact, this is where you need a new way of looking at budgets. So, you know, Manchester's trying to do it because they have a devolved budget, and they actually understand that relationship between inequity, long-term unemployment, social deprivation, healthcare, you know, so this whole relationship. And somebody said something about counsellors and not understanding this, and so I think more research and more arguments need to be there to actually enable counsellors, officers of all kinds, not just planning and public health, but transport, to again do some systems thinking. But in that system, we need to understand short-term investment, long-term value, you know, the costs and value again. So I think there's some more work to do there, because you can get all the health evidence you like, but when it comes down to pounds, particularly at the moment, that's where you need really strong evidence to say, you know, this is a long-term thinking. You may be in you know, in government, in local government for 5 years, but actually planning is a 20-year. And what I'd like to bring in there, and I'm going to advocate to do some design speculation. So people do planning, and they do planning for 20 years, but actually they're usually two-dimensional plans, and they do all sorts of assessments on them. But actually we need more world building, and this was just done in Wales about what will this place be like in 2050, how we live in it, how we feel about it. And these are the sorts of things you can do with communities. So I've gone a bit away from that value stuff, but I think we need new ways of getting people's minds to think.
Definitely. Thank you. Carl?
Michael, if I could just add in, just to say, I mean, I think, for example, just picking up on Rachel's point there, I think, for example, I mean, there are limits to planning per se, and as we start moving into things like retrofitting of all the poor housing in the country, things like that. It's not a planning issue per se, but it is obviously a cost and price issue. And, you know, when, you know, the assessment that I showed, poor housing costing the NHS, you know, 1.4 billion, that's probably about 2.5 billion. At the time, the Building Research Establishment, which did those figures, you know, said if you invested now in improving the homes which weren't meeting decent home standards, it would have a payback within, I think it was 7 years, that you would see the payback. Now, that is the long-term cost and price. And, you know, the challenge, as it is always, is how you get that money up front. I think the only thing I would say as well, you know, so I think it's really a challenge for us, particularly in public health, when we're putting these sort of things, is trying to show what the return on investment can be, and it is difficult. I guess the rubric that I sort of go around in my head with is generally, thank goodness, what we find, what's good for health is good for the environment and is also good for the economy, and, you know, in the long term thing.
Yes, Liz?
Yeah, I think it's about not just pounds and pence value, but the social value. So you talk about return on investment, but actually social return on investment, social value, which goes back to what Matt was saying and Rachel was saying about good design, about it being about, you know, building better places that will enable people to have long, healthy, fit lives, and in a variety of ways. You know, health in the pandemic, we saw if you didn't have your health, you didn't have a healthy workforce. If you couldn't work, we're now seeing statistics after the pandemic where, you know, there might be high levels of employment, but there's also high levels of those who can't work because of ill health, or, you know, not many people's mental well-being is shot to bits. And so it's about that sort of broader thing about economics, like you're saying, Rachel, systems thinking, but social value as well as economic and health value.
Rachel.
Just coming back on that, and the other, we talked about the public sector, we talked about community, we haven't talked about the investors and the developers and the international investors here. And this is where GRESB comes in, you know, the whole responsible corporation, B Corps, thinking about their responsibility. And as I'm not sure the health agenda will do it, but I think the climate change agenda might push the international investors, the city, to start thinking about using, you know, GRESB and other measures. Now, I've looked at GRESB, and I looked at a lot of developers who write these wonderful brochures and say, we've done all this green stuff, we've done all this, you know, environmental stuff, great. And then we've got the social, and measuring social benefits going forward of a design is really hard. And, you know, and sometimes developers will not pay for a consultant to come in and do a social value of a plan going forward. So again, it's changing that and getting people to see, you know, that it's not just green, it's not just the greenwashing. We have to get off social washing and all those things. So I'm sorry, I'm a bit of a skeptic, but what I'm saying is we're always having to challenge it all the time.
So just to kind of say, we do have Rachel, you're at Lancaster University, and I know Liz and Carl, you're visiting professors at UE, and then Matt, you're working in local government. And there are a few comments in the chat, or a couple of comments around the skills of professionals and public health registrars coming forward, whether they have the right skills or receiving the right kind of training and knowledge to be able to work in this agenda. One of the things that we do highlight in the book is the different systems of education or postgraduate education around this particular agenda. So in the UK universities, we may have a Healthy Cities module as part of a master planning degree, whereas in America, you have already joint degrees where you have a master in planning and the masters in public health together. So you come out of university already equipped to take action, whereas in the UK, you kind of still have to be upskilled a lot more when you come out of university around this particular agenda. So I wonder whether, you know, Matt can mention things around the skills of the public health workforce and the registrars coming forward, and as well Rachel from the university side as well. Thank you. Has Matt gone? Rachel, go ahead. Yeah.
I can talk about, well, we're actually writing at the moment a master's in urban futures to actually address that. Now, this is interesting because I think the university might be, they're thinking, well, who is going to come on this course? Because when you write a course that's an amalgam of these things, people go, well, which profession is going to come on that? So I think that's a challenge. But I would like to come on to education. There was a comment earlier about communities can sometimes, getting communities can actually sometimes be negative because they don't want a bike lane, or they don't want, you know, windmills, or they don't wind farms. And actually, education doesn't start at university level, and education doesn't start at postgraduate. I really do think school curricula, and that's where the young people are going to understand the agenda and change the mindsets of their communities, you know, move away from cars. We know that it's the younger people who are not driving cars as much as, you know, older people, that younger people in cities aren't wanting to own a car. So we need also to think about education at secondary and right the way through. It's a life education, actually.
Thank you. And just before Carl comes in, I know the Road Town Planning Institute have have programs aimed at secondary or primary schools as well. So and I know CAVE used to have those educational resources for school environment as well. So yeah, definitely agree with that. Carl?
I mean, we still have a way to go, certainly in public health. Unfortunately, there's been a brand new curriculum that's come out from the Faculty of Public Health for trainees to become, get on to become public health consultants eventually. And the words built environment does not appear at all. Planning appears in a sort of context. So we still need to work for the next revision to get something actually into that bit of the curricula. But I don't want to sort of end on a negative note, because there's lots that can be done and has been done. And I must say, just over the past 12 years or so since I've been immersed in this, I've seen a distinct change. When I used to sit down originally in groups with planners talking about health, they were talking about the health service and the NHS and hospitals. And, now I think when I sit down with planners, they get it. They understand around active transport, active travel, housing and design, and how that contributes to health. So I think we have shifted. I think there was a comment earlier on around still a lack of, how we develop this common language between, planners and built environment professionals and public health. I can tell you the first meeting I sat down in, we were talking about HIAs, and I thought this was fantastic. All these planners are talking about health impact assessments. I later found out they were talking about the Home Improvement Agency, but you're on mute, Michael.
Thank you. Just going on to the HIA issue, I think it was Graham from Essex was mentioning whether impact assessment is sufficient on their own to address health issues, whether they should be built in upstream. I think someone mentioned those issues. Is impact assessments the only tool that we can use, or are there other things that we can use as well, Liz?
There are a lot of other tools. In Scotland, they have the place standard, which is a way of engaging with the community. So there are a range of tools. I mean, if you want to explicitly consider health, well-being, and the distribution of effects across population and inequalities, then HIA is the best tool, but it is not the only tool. And, I mentioned environmental impact assessments, strategic environmental assessments. You can build a consideration of health well into those, but it's like I was saying, it's about the perspective you take and the evidence you use, and how they often have consultation processes where you could, instead of it being a passive thing, you could actually take it out to the community or to the key stakeholders and run a health impact assessment workshop for half a day and get some real value back from that. And I think that's why Wales has been quite successful in voluntarily carrying out HIAs. And we have a number of very strong planning policy, planning officers in Wales, in local authorities, who are strong advocates for health impact assessment because they've reaped the benefits.
Thank you.
I think sometimes the block in the system might be the developers, because they see it as another barrier and another burden and something to be paid for and a cost.
Yeah.
But that's not to say that there aren't some out there who do see it. And I know you've worked with people previously, Michael, around investment and development. Yeah,
thank you. Yes, it's not the only thing, but it can add value when it's used in the right appropriate way. Thank you. 2 or 3 other kind of points before we finish today's event. So let's come on to climate change. I know it's COP27, and I think it's very timely. And there's always this issue about we talk too much and we don't take any action. So what actually do we need to be doing, and how can the public health sector help with this, or how can the planning sector help with this if not already doing something around this? Shall I come to Rachel and then Carl with UKHSA? Rachel.
I think I've said everything. I think I think we just keep on needing to. We need more evidence around how we can help people do it. you know, both the local authorities, the councillors, the planners. We need more analytics to help them have the evidence in their local place and the skills to do that. And we need more evidence to help them invest in it and knowing they're going to get payback and benefit. So I think that's what I think we need.
Thank you. Any words from you, Carl?
I mean, I think I would just echo again what Rachel just said. It's around trade-offs. People do get it, I think. And it's also, I guess, something that's around, you know, thinking big, but acting locally. And, you know, you're not going to change everything all at once, but in your local area, you know, for example, putting in a low traffic neighborhood, it is a challenge, and it's not straightforward. But we know that that will help support, contribute to reducing carbon, etc. And that's where we need to take things where we can. At a national level, you know, again, I think there's work going on across government that, as a public health professional, we do need to influence. And you know, the Lancet has said the biggest public health challenge facing us is climate change. So it is fully square on the public health agenda.
Thank you. And just to kind of finish off as a comment, I think just going back to the governance and devolution type issues, and it's very relevant now with all the different things happening with the Levelling Up Bill. So Ellen Lodge asked, work in Manchester has been mentioned. Is there a role for strong metropolitan mayors to bring planners, developers and others together? Could be metropolitan planners, could be combined authorities and any other form of political leadership. So Rachel, any comments from you?
No, I think we've said it, and I think Carl just said it. You know, think big, act local, and have the powers to do it, which we need to do, basically.
Thank you. Any concluding comments really from you, Liz and Carl, before we finish?
No, I mean, it's been fantastic. I've been sort of sorry, I've been on the chat. The chat is fantastic. We've had some really great comments, some really great feedback, some really relevant points, and also some sharing of practice, which is great to see. So this is always evolving. I think climate change and the pandemic will provide windows of opportunity for us all, as much as that sounds really bad, because they're not good things. But I do think that, you know, public health, the use of health intelligence and health evidence to help shape the future will be quite critical, I think.
Well,
I think the only thing I'd like to say again is to thank you to everybody who's joined, and to Michael and Liz and Rachel today as well. But yeah, we've got a core of people here from planning and public health, and I don't know what the split is between people from those sort of professions and others who've joined us today. But I think we do have a corpus of people around the country who can try to take this agenda forward. And I guess from my perspective, I hope the book will help you in doing that and provide some insight to try to help take things forward. Thanks again.
Thank you. Any final comments from you, Rachel?
No, I think it's fascinating to see the different perspectives and the different community, as Carl said, and I actually hope that this community does have a space to have these conversations, because I think it's quite important, and it will help us in academia develop most appropriate courses and take more action locally. So this is a great sort of webinar, and thank you for inviting me.
Thank you very much. And I know Matt, he's not here, but thank you, Matt, for his contributions, and I'll email him later on. So to finish up then, so thank you, Megan. There is a health and wellbeing and planning kind of peer support group, and I can send you the link to that. It's a network. But if you're in London, as I mentioned in the chat, there's a London Healthy Places group that draws people together across London on these issues as well. Liz, do you want to comment before we finish?
Yes, just to say that Wales, Public Health Wales, in February the 9th, will be having a morning that will have these kind of discussions, that will bring spatial planners and health professionals together. I'll put the registration link in the chat, although it's primarily for Wales. We had one last year and we had a huge range of people attend, and everybody is welcome.
Thank you very much. And just to say, because Liz, Carl, and I, you know, in our day jobs, we do this, you know, as our day job. So, but the book was done outside our day jobs. But I'm sure many of you will hear from us separately, you know, as part of our day jobs to take some of these things forward. So thank you very much for your time and contributions today, and our panel speakers, our authors. And again, you know, any questions you have, please get in touch and we'll circulate anything that you need after today's events. So thank you very much and have a great weekend.
Thank you.
Thank you, everyone.
Thanks. Bye.